I'll try to be as quick as possible. So I'm coming from the Eliava Phage Therapy Center. It's EPTC for short. We are affiliated with world-renowned Phage Eliava Institute of Bacteriophages, Microbiology, and Virology. Under the Eliava Consortium, Eliava Institute operates several spin-off companies alongside EPTC, such as Eliava Biopreparations, Eliava Analytical Diagnostics Center, Eliava Pharmacy, and Eliava Phage Service. So this is this whole ecosystem, and we have close collaborations with our fellow researchers, experts, microbiologists, and this close collaboration gives us chance to stay informed about not only like medical aspect of the phage therapy, but about the scientific works, to conduct trials, to write publications, etc., etc. All of this eventually results in the comprehensive patient care and in the satisfactory phage therapy within the patients. So this is the on this slide, as you can see, there is our clinic. It's an outpatient clinic, and we have several different doctors there. Not only several, but a couple of the doctors and I'm from the internal medicine department. We have urology, we have pediatric department, we have surgical unit, we have ENT doctors, etc., etc. So I know it's we have a short time. We are short of time, and I will try to be as quick as possible. And our clinic is patients are coming from all over the world. And as you can see on the visuals, there is a distribution of the patients receiving phage therapy from the EPTC. As you can see, the leading countries from which patients are addressing are India, United States, France, Germany, the Netherlands. As you can see, the Netherlands has a big portion because there has been a huge media coverage over there, and patients have been addressing us for a couple of years. We've been established for 13 years, and we usually receive hundreds of patients a year, and most of them are like coming from like 8 different countries every year. So we have 2 different therapy options. One is a remote therapy option, and another one is a local therapy option. As you can see, we try to help as many people as possible, and we have, and on the statistics, you can see the total number of international patients that have arrived since 2018 up until this year, April. As you can see, within the years of 2020, 2021, and 2022, there has been a decrease in the numbers. Well, there are 2 big challenges that happened during these years. One was global COVID-19 pandemic that really changed the whole world. Another issue that has been happening is a regional conflict within our area. So these 2 factors contributed in the lesser number of the patients who arrived on site. But during this time, we particularly refined our remote therapy option, and even especially during COVID-19, we had lots of patients because there has been like secondary bacterial infections has been a huge issue, and with the bacteriophages, we try to help as much as possible. On the graph below, you can see the most common medical conditions that have been routinely encountered by our healthcare professionals. As you can see, bacterial prostatitis, local infections of skin and subcutaneous tissue, urinary tract infections, have IBS. Those are the most common diagnoses the patients have that address our clinic. On these graphs, you can see the most commonly identified pathogens at the EPTC. As you can see, E. coli is a leading pathogen, followed by Enterococcus faecalis, Staphylococcus aureus, Staphylococcus epidermidis, and several others. The graph on the right side shows us most commonly developed custom phages for the personalized use. So we have 6 commercially available phage cocktails. Out of 6, 5 of them are broad spectrum, and the 6th one is a staphylococcal phage. So if certain bacteria are resistant to these cocktails, we have a possibility to prepare a customized, like individual phage preparation. And as you can see on the graph, Klebsiella pneumonia custom phage is the most common one that is being produced. That is because, unfortunately, in our broad spectrum phage cocktails, we do not have a Klebsiella phage, but we are working on it, and that will happen very soon. On the graph below, you can see the statistics of the customized bacteriophage preparations that have been developed over the years, and this decline, as you can see, so this number is of the half a year. So of course it needs to be updated, and the number is way higher right now. So not to mention the diagnosis and the medical conditions that we are working against. As you can see, we work with the respiratory system infections. Most commonly, patients are having bronchiectasis, where there are secondary bacterial infections quite common. We work with the cystic fibrosis patients, primary ciliary dyskinesia patients. Within the other organ systems or genitourinary system, UTIs are very, very common with the patients that are arriving at our clinic. Within the EAP, chronic sinusitis is a very, very prevalent condition. With our surgical units usually sees chronic osteomyelitis quite often. One very important thing that I wanted to underline is the fact that people with the chronic recurring bacterial infections rather than with the acute ones. And with the chronic infections, biofilms are way more prevalent, and where it's very, very difficult, of course, as you know, to work against it. But with the phages, we have more results with the biofilms rather than with the antibiotic therapy. So with this long-term, with this chronic infections, we have the chance to observe the long-term dynamics and see how the patient's well-being changes over the years. Other than the most common diagnosis, we also work with some very rare medical conditions, as you can see, cytosine versus IBDs, Netherton syndromes. We are not working against these diseases itself, but with these conditions, bacterial infections are quite common. Of course, the data and the statistics are important and interesting, but I think it will be way more interesting to discuss a couple of patients' cases, and I will start with the respiratory case. So this is a case of a 64-year-old female from Germany. She has a primary ciliary dyskinesia and bronchiectasis. So PCK is a condition that is caused by genetic mutations that affect the cilia within the airways that became damaged, and they can't really work well. They can't really take out all the germs and the mucus buildups, and eventually this results with the recurring bacterial infections. So this patient started her therapy in 2018. Her main motivation to come to the EPTC was to exchange antibiotics with the phages. So her health status was very, very serious. And her quality of life was very poor because on a daily basis, she had like shortness of breath, productive cough, low energy, general malaise. She was admitted to the hospital numerous times a year because to get the IV-infused antibiotics to combat Pseudomonas aeruginosa infection that has been traced in her samples for years and years. So first of all, we started the culturing, and of course we saw Pseudomonas aeruginosa, and unfortunately, pyoid intestiphages that are most commonly used for the Pseudomonas aeruginosa infection could not have been considered for only options for the therapy, because from the very first culture, her bacteria was resistant to these phages. So we had to prepare a customized phage and administer that. She also had staphylococcal co-infections, and we used commercial phages, we used custom phage and anti-staphylococcal phages to start the therapy. One important thing to note is that with this patient, we could not use inhalations, which is the main route of administering phages while having lung infections. She could not tolerate them, and we had to give her phages only orally. Nevertheless, she immediately reported of improvement, and that resulted with less cough, with less produced sputum, with increased energy. As she said, like her life has been changing since 2018 in a positive manner. As you can see on the graph, the custom phages are still being prepared. So this patient still undergoes phage therapy. And during the past 5 years, she successfully switched from the antibiotics to the phages fully, and she only got admitted to the hospital only 2 times. And this was because she had some additional health issues, and they had to use antibiotics for a very, very short period of time. Other than that, she also had very unluckily COVID-19, which successfully resolved in her case. It was very lightly manifested, and which was very surprising, and we were like pleasantly surprised because her lungs were very damaged due to this her primary severe dyskinesia condition and the irreversible damage that has been done over the years. Other than this case, as you can see on the below, there is a statistics of the respiratory system infections that we see at the EPTC, as I said, bronchiectasis, cystic fibrosis patients, COPD, and other conditions are quite common with the patients who come to our clinic. The second case refers to the surgical, is of surgical nature. Starting with the statistics, we quite commonly see osteomyelitis, intraprostatic infections, chronic wounds, diabetic foot, etc., etc. This particular case refers to this case of tissue infection, and as you can see on the pictures, the wound was quite big. It was a 30-year-old male this year who presented at the EPTC with a wound that was coming from, he was working at the factory, so it's like worker-related injury that he sustained. And as you can see on the pictures, his wound was looking quite gnarly. The wound was very deep, it was severely inflamed, the pus was losing. So we started the therapy. At first, we of course did the culture test. We isolated the strong growth of the. We isolated Staphylococcus aureus with a strong growth, and we initially started the therapy with staphylococcal phage. And we used, of course, oral intake in his case as well, but also applied phage ointment to his wound. Within the 2 weeks, as you can see on the pictures, within the third day, we already saw regranulation process, and the edges of the wound were getting cleaner, so to speak. The hyperemic reaction was going down, and the pus was slowly decreasing. It was excessive amount at first, but slowly. By the 14th day, as you can see, the wound is almost fully closed. Like 70–80% of the wound is closed. It's like regranulation is happening. And by this point, the pus was not coming out. It was like a very small amount. And by the 21st day, the wound was fully closed. This patient is still in contact because his work nature, and he often sustains the injuries, so we are always in touch with this patient. Another surgical patient is this young man, 47-year-old man, back in the 2018. He was in Italy when he had a accident, motorcycle accident, and then he had broken bones within the shin. And in the Italy, they had surgeries. They inserted, as you can see on the pictures, external fixators and started therapy. Several surgeries, antibiotics were used, but over the several months, the wound did not heal. The fistula opened, the chronic osteomyelitis developed. After that, the patient underwent several more surgeries, wound debridement, antibiotic therapy, but nothing was helping. At this point, we are very thankful for his doctor, who's very familiar with our clinic and often collaborates with us. So he referred these patients to us, and the patient arrived at the EPTC in 2019. So we started with the culturing, of course, and Pseudomonas aeruginosa has been the bacteria that has been always coming up in his analysis. We started with the pyoid intestine bacteriophages, and we use phages orally. We use phages to apply into the sinus, into the fistula, because there were like several openings, as you can see. And we also cleaned the external fixators with the phages. Within 2 weeks, the hyperemic reaction has been reduced. The pus amount has been reduced. The swelling has gone down. The redness has gone down. The patient was feeling better and better, and most importantly, after 2 weeks, Pseudomonas aeruginosa was not traced anymore. Unfortunately, Staphylococcus aureus came up in his last analysis, but his treatment plan was adjusted. We used anti-staphylococcal phages as well, and discharged the patient who went back to Italy. This was happening in 2018. And he continued the therapy for the next 3 months. By 2020, we did not hear much from him. We only knew that his wound was completely closed. He didn't have any complaints. The external fixators were taken out, and he was feeling fine. Unfortunately, the fistula reopened in 2020. On the fourth month, and still his analysis showed back in Italy both Pseudomonas aeruginosa and Staphylococcus aureus again. And right now, at that time, he did not arrive at our clinic, but we provided phages remotely, and with the help of his doctor, we administered phages pyeloid also staphylococcal one, but this time antibiotics were used as well, but only for a very, very short period of time, 10 days. This therapy, this round of phage therapy continued again for the next 3 months, and eventually resulted in the resolution of the infection. Fistula has not reopened after that. Patient is completely healed, and he even underwent a limb lengthening surgery because he said he was not looking cool, and he resumed riding his bike, and we are hoping we are not gonna hear from him anytime soon with the broken legs. So the next case refers to the Netherton syndrome. It's a quite rare syndrome. It's caused by genetic mutations, and with this patient was arrived at 2016. He was a 16-year-old French male. So with this Netherton syndrome, bacterial infection is a secondary one. This is the most important aspect of this disease is exfoliating dermatitis, and this damages, as you can see on the pictures, this damages skin so much that he always gets the infections, and Staphylococcus aureus was the most common bacteria that has been coming up in his analysis. We had two challenges with this patient. One was the antibiotic resistance, because he has been using antibiotics since the very, very young age, and he became resistant to most of the antibiotic groups. Another challenge was the allergic reactions. We could some antibiotics that were sensitive, he was allergic to those, and he was allergic to the general skincare products as well. So it was very challenging to manage this patient, but we started the therapy with the staphylococcal bacteriophage. So the administering phages with this patient was a bit difficult because his skin was so damaged, the thermal regulation was not working well with him, and we would apply like sterile gauze, as you can see on the picture, sterile gauze on his body, and then slowly, very slowly, pour the phage of this gauze and apply phages like this alongside the oral intake. Of course, it would have been better to apply already phage soaked gauze, but he was not feeling, he had shivers and he was uncomfortable. But with this way, he was way more comfortable, and he was feeling quite fine. As you can see in these pictures, they are like taken within the 2 weeks, and we immediately saw improved state of the skin. The redness has gone down. This Staphylococcus aureus, of course, will be coming up in his analysis, but we are managing the bacterial load of this Staphylococcus aureus. And with this patient, he had to get admitted to the hospital numerous times a year because he would become like septic like 3, 4, 5 times a year. With this phage therapy, he has not become septic. He has been using phages continuously, topically, but not with drinking phages. We have reduced the amount, and we have altered his therapy quite a few times. But with the general skincare, with the phages using locally, he's doing that on everyday basis. The most important thing was that the bacteria has been sensitive to phages over and over again, and he did not have any allergic reactions. He did not have any resistance, and we really changed this patient's life because due to his condition, he was not looking looking okay in his mind, and his social life had been severely altered. His mental state was not okay. But right now we are seeing this patient several times a year, and he is completely different person from what he was back in 2016. I think that should be it with the patient cases. This is my team, and I'm here with my colleagues who have been the leading doctors in all of these 3 cases, and I'm very thankful for their guidance. And we are open to collaborations and everything. And if you want to talk, I don't want to take too much of lunchtime, so you can find me somewhere over there and ask questions or anything. So just thank you for your attention.
Well, all our speakers have been perfectly to time, but obviously there have been some other delays, so we are a little bit running behind. Does anybody have questions for Mariam? Yeah, okay.
So that's a very individual, depends on the case, but in most of the cases, patients who are coming to us are either antibiotic resistant or are having intolerances or are allergic, and they're are using phages for several years, and they have severe side effects. So it's very individual. Some of their goal is to use phages all the time, but of course, if there are some severe infections, the combination of phages and antibiotics, as you know, works well, and in some cases we have to introduce antibiotics as well. But our goal, and also patients' main goal, is to use phages because of there are no side effects or anything like that. So, but of course, if there is a need for any additional medications, of course we are really open to that, and if we are not against antibiotics or anything like that, we are using everything to help the patients.
Any other questions? There's one at the back.
Thank you for a really lovely talk. I just have a question about your patient who had the Pseudomonas aeruginosa infection.
Sorry, which one?
The patient who had the Pseudomonas aeruginosa infection, and I think they were receiving phage therapy over the course of 5 years. In your table there, you've got the dates when you gave your phage therapy. Was it a different phage cocktail or a different phage you were administering each time, or was it the same one? And if it was a different one, do you know why you had to administer a different one? Was it that was it a different strain of Pseudomonas aeruginosa infecting and it become resistant? Or the patient neutralizing antibodies against your phage? Do you have that data?
Thank you for your question. That is a very interesting aspect. We also, with this case, we closely collaborated with the microbiologists because we also wanted to understand what was going on, and there has been numerous. These are the castophages that were used in her case, and out of this, I think it's more than 10. Out of this 10, there were 2 castophages that have been different. Other times other 8 were the similar that has been produced initially, and then we were just reproducing. Only during 2 times it was different, and our microbiologists explained. I think that would be more interesting to discuss with the microbiologists, and they would explain it in more details. As a physician, I do not know the exact detail what has changed and what has remained. All I knew was that the new castophages were working perfectly. In this patient's case, the bacterial load was slowly decreasing, but we could never see a whole resolution of this bacterial infection. It's impossible with the damage that's in her case. We are not even expecting that. But the castophages that have been administered to her, we're quite efficiently are managing the infection.
One last question down here. Can you pass the mic forward?
Thanks for a lovely talk. Can you tell me, do you have any concerns about bioavailability of oral phages if you were ever forced to use only oral therapy?
Sorry, can you? I couldn't understand.
Sorry, it's just about bioavailability. So, if in circumstances where you don't have topical option, you don't have a wound or something,
Mhm.
is oral therapy, in your view, commonly successful? Is bioavailability reasonably reliable, do you think?
That's an interesting question. So usually in like 9 out of 10 cases, the oral intake is the main route of administering, and even we have patients where we can't administer phages from the outside. We have phage ointments, we have phage suppositories, we make patients inhale the phages, but the oral intake is always important. And in some cases where we have closed wounds, when there is a intraprostatic infections, where we can't really take a sample or administer phages from the outside, the only option we have is to use empirically phages and to make the patient drink. There is no other option. And in that cases, we see good results and a positive outcome despite these huge challenges. So that gives us the courage and experience to even to use phages orally in most of the patient's cases where we can't really administer in other ways. Within the bloodstream, our phages, like within the 2 hours, they usually go to like they try to find the bacteria. So with the oral, our main route of administering is still oral intake. So we are quite happy with that.